Hello, welcome. Good afternoon, good morning, everybody. We are being joined by Chris Jackson from ReceptivaDX today to discuss breaking the silence on silent endometriosis, understanding what that means, testing available, and how this can help with fertility. So I'd like to start by introducing you, Chris. Please tell us more.
Oh, okay, very good. Well, I think the first thing I want to do, in addition to introducing myself, is just to make sure everyone knows I'm not a physician, so I'm not here to dispense any medical advice. I am here to educate and to help you become a great advocate for yourself and your own fertility journey. And that's what we're all about, getting you as much information as possible so you can make some educated decisions and have great discussions with your provider. This is an area of medicine where you have as much say as anybody. It's consumer driven for the most part, depending on what part of the world you're in. And it's really up to you to have this information so you can have meaningful discussions with your healthcare provider. So my name is Chris Jackson. I'm the president and CEO of Cicero Diagnostics. We do the ReceptivaDX test, and I'll get into that a little bit more. But my whole purpose for being here is to educate you on silent endometriosis in general, and then how our test fits in and how it's kind of helping resolve some issues, which is how do we find endometriosis much sooner, especially for those with fertility issues.
Absolutely. Well, welcome. Thank you very much for your time tonight. It's really kind of you. I'm Eloise. I'm the CEO and founder of The Ribbon Box, and we're delighted to welcome you tonight or today to answer these questions because it is a very, very interesting topic and something that affects, as we know, many, many people around the world.
Very good. So the topic that we are talking about today is silent endometriosis. And before I really get into silent endometriosis, I think it's only fair to really just talk about endometriosis in general, kind of paint the big picture, and then we'll introduce what silent endometriosis truly means. So I promise I'm not going to hit any graphic pictures up here of anything that might not make your dinner enjoyable or whatever. But I wanted to give you a concept here of what endometriosis is. And this is an illustration showing these adhesions that have found their way outside of the uterine cavity and are latched on. In this case, there's scar tissue and these implants on the ovaries, as well as the outside of the uterine wall. That's just an example of that. But endometriosis essentially is pieces of your endometrium tissue that have found their way outside of the uterine cavity and are attached elsewhere. Now, normally the endometrial lining builds up during a period and then is removed during your period, and everything's fine. But there's also parts of these little pieces of tissue that can find their way back. I guess the best way to explain it is instead of going through the vagina and out in your period, this is happening and going back in reverse, going through your fallopian tubes and going back out into the pelvic area and finding their way and attaching. So the most common areas for endometriosis lesions to attach to are the fallopian tubes, the ovaries, and in general in the pelvic area. And depending on their location, this is where pain can come from. And every month, while your endometrium lining is building up, these implants are getting that same signal to build up. Yeah, but they're in places you wouldn't want them to be. So they're on the outside of the ovaries, they're in the tubes, and they're inflaming as well. But instead of being shedding off during a period, they bleed and cause pain, but that blood has nowhere to go. So cysts can form, all these things. So it really depends on how long this has been going on for a particular woman, on what kind of damage can happen. So it's usually benign tissue growths. There is a very small relation to ovarian cancer and a few other cancers, but for the most part, these are benign tissues that just kind of wreak havoc. And they're just a real pain in the rear to try and figure out, what's going on and what's causing that. Because let's face it, we're dealing with, for the last 20, 30 years, a male-dominated GYN industry, and for them to hear you say, "I've got this pain and everything," sometimes it's very hard for them to decipher, well, is that normal? Is that your monthly pain and you just have low tolerance or what have you? So endometriosis has been really difficult for a lot of people to identify and diagnose. So here's two images. This is normal female anatomy on the left. On the right, you can see where endometriosis can happen. And so I'll get into a little bit more of cause and effect here and how it can impact fertility, for example. But you can see, obviously, if endometriosis attaches on the outside of the ovaries, there's all kinds of damage that can happen there. It can diminish your egg quality. It can actually cause a cyst and burst and destroy eggs. There's all kinds of things that they're concerned about that can happen here. Most often, it's just a lot of general pain that happens once a month as your period is approaching. And a lot of women just associate it with their period, but they don't realize it's these lesions that found their way elsewhere in the body that are becoming inflamed once a month. So when we talk about endometriosis, there's kind of three things that you'll hear about. You'll hear about endometriomas, you'll hear about scar tissue, and you'll hear about inflammation. So the endometriomas are these benign growths. There's a nickname for them, the chocolate cysts, and that is because it's dried blood. It's blood that has found its way and formed in clumps and will attach to different things and can cause all kinds of damage. So they will go in and look for these endometriomas and hopefully be able to remove them. Sometimes if they're on the ovaries, they're worried about your eggs and the ability to remove those without doing damage. So endometriomas are a major concern. The other thing that they can do is block the fallopian tube. So here you are releasing an egg, but the egg can't get down the channel because the fallopian tube has been closed by this pending pressure on the outside. Scar tissue is very common. Scar tissue on the endometrium lining is very common. Women will have these removed. That will help their fertility, but it can be anywhere. And the biggest thing is that, like we said, these things will inflame once a month, so it can cause all kinds of painful symptoms. The last one is the one area that our doctors that were involved with the development of the test and everything is about inflammation. Inflammation as a whole is just never good. It's the body's immune response to everything, but it makes, as we say here, the reproductive chain less efficient. And when you're less efficient, you have a less capability of having that embryo stick and stay stuck and allowing you to have a full pregnancy. So just a little thing off to the side there, this isn't just comments that I'm making. This is well known in terms of the presence of endometriosis having an effect on folks' fertility. It's been well studied. We just don't look for it as much as we used to in the past, believe it or not. So now we're going to get into silent endometriosis. So is it really silent, or is it just not recognized? I think that's the big question for a lot of women to consider. If you look on the diagram on the left here, those are all the classic symptoms of endometriosis. But if you get around to the 3 o'clock position and you see infertility, well, guess what? Chances are you may not have any of these other symptoms. You may just have your infertility issues. And the reason for that is the location of your particular endometriosis. It might not be in an area that is causing you that severe pain. So you'll hear me refer to it as not your mama's endometriosis. You hear about people complaining about this pain, and you just think, do they have a low threshold? They can't go to work. People, making comments about them because they're drama people. I mean, they are in some debilitating pain. But women that have silent endometriosis, they don't have any other physical symptoms. The only symptom they are beginning to recognize is their infertility. And so what we do know is that unexplained infertility is about 40% of it is known to be caused as a result of the silent endometriosis. So it's a very interesting thing. And the reason I say, is it really silent? It's a lot of this is because sometimes we have these symptoms over here that are physical that we never associated with endometriosis. You just thought that was part of your period, your cycle. And it was difficult to explain that to your physician to get them to do anything about it or to take note. In the past, when women went for fertility services, they were scoped. It was part of the routine workup, and they would find endometriosis in 2 to 3 out of every 5 cases, and they would treat it, and the women would go on. Well, in this day and age, laparoscopy, first of all, it's invasive. Second of all, it's expensive. Third, you've got to be the squeaky wheel to get the approval through your insurance or what have you to get it done. It's just not offered that often. So it's really a case of we stopped looking for it as opposed to this being a new problem. So it's very interesting that we used to find it all the time, and now we just kind of neglect it. And fertility centers will just say, well, we do IVF, and therefore we don't have to worry about endometriosis. And that's partially true, but it's not true for that 40% of women that have silent endometriosis where their fertility is challenged. Okay, so is it always going to cause fertility issues? The answer is no. There are women out there, especially younger women, especially women with great embryo reserves that are young, that have young eggs and everything. Chances are they can get away with it depending on where their endometriosis is and the effect. So a good half of these women have no issue at all. And so it's not an issue for them. And fertility doctors will say it's not an issue. We're going to do IVF and we're going to bypass the tube where your inflammation was. But the interesting thing is there are still women that have impaired fertility, even if they're going to IVF, even if they've had their embryos genetically tested, there's still a high percentage that are failing. And it's a result of inflammation on the uterine lining. It's not the tissue that's blocking the tube or anything like that. It's this inflammation that is creating an unfair playing surface, if you will, on the uterine lining that's doing a couple things. It's not allowing the embryo to implant, and it's not allowing the embryo to stay implanted through the first trimester. And that's a challenge. And that's what we're doing a lot of education with doctors now on the use of our tests and the use of treatments to kind of reduce that inflammation. And that's important because, you listening to this seminar, I'm afraid to say a lot of you are going to know more than some of your doctors do about not only our test, but silent endometriosis. And so it's all about empowerment and being able to have the right discussions with your doctor. Okay, so Chris, you brought this all up. So what are the treatment options for silent endometriosis? They're the same treatment options for any endometriosis. So as I mentioned, laparoscopy, it's been around for a long time. Again, it's difficult in some countries or depending on your healthcare system to be able to access. In America, it's either costly or you really have to be the squeaky wheel or demonstrate all kinds of things before you can get it done. Unless, of course, you have money and that type of thing. But it's not routinely available. But in the case of silent endometriosis or endometriosis, this is the proven option. It's the only true way to diagnose endometriosis. And that's important to understand. Even our test that we're doing, it helps detect endometriosis and give you a strong likelihood there is. But until you go in and look with the scope, that's the only way you can do that. So here's the problem. This is great because it can go in and not only find these lesions and everything, but they can go and excise them. So they can do it all in the same procedure. It's pretty darn cool. They've got a scope in there and they've also got another device there. And yes, it's invasive. But if you are having lifestyle issues that you never thought about that were now really associated with endometriosis, and I'm talking the heavy periods, the painful bowel movements, painful intercourse, all these things are lifestyle issues. This is the only way you can get rid of those is by laparoscopy. So that's the really cool thing about laparoscopy, and that is a great choice for women, especially those with these symptoms. Now, there's an alternative, and that's great news for a lot of people because you not have any symptoms, and all of a sudden everyone says, hey, you've got endometriosis. Mentally, it's a hard one to overcome because you haven't experienced anything. It's someone telling you something's going on, but you haven't experienced any symptoms. Just raising your hand, say, take me to surgery. Let me shell out this money. I know women will do a lot of things to get pregnant, so I'm not underscoring that, but undermining that. But what I'm trying to say is that there are a lot of women that would prefer to do something that's less invasive. And that's what this is. This is a non-invasive hormone suppression therapy. Now, it's not fun. Now, just to give you an idea, the Depo-Lupron medication is working very effectively, but it does have some fun side effects that are going to take you on a little bit of a roller coaster. The good news is they can give you estrogen blockers and things to make it a less terrible experience for you. But what Depo-Lupron is doing, and it's a great alternative, is that it is kind of shutting your body down. It's putting you basically in a menopausal state, and for about 60 days. And that's better than just being on birth control, because what this is doing is it's suppressing everything, and it's not allowing the endometrial tissue to grow. It's not stimulating it. You're blocking estrogen, and estrogen is the big culprit behind endometriosis. And so by doing this, you've suppressed everything. So it doesn't treat anything long term, and that's an important thing, a point I want to make. But what it does is it allows you to get pregnant and stay pregnant a good majority of the time. And we have some great outcomes data that have been shared with us by our clients and in the literature that shows that more than 50% of the women end up with a live birth on the very next transfer after going through Depo-Lupron. So in our data that we followed up with patients in our centers that we work with in the US and abroad, over 75% chose the Depo-Lupron over surgery. And that's an attestament to how well this works, but also an understanding that, you know, surgery is a great option for those who need it, but here's an alternative if you really don't want to consider surgery. So I'll talk a little bit more about Depo-Lupron and some of the question and answers that you have there, but it's a nice alternative that you can discuss with your doctor. There are other types of hormone suppression therapies. This is the only one I can address in this talk because it's the one that there's published data on, and that's what I want to be able to present to you, is where there's published data, proven clinical data to support these things. And right now, surgery and the hormone suppression therapy are those two treatment options. Now can tell you a little bit more about our test, because the question then is, well, how are we going to identify silent endometriosis if I think I have it? My doctor is at wit's end. They just want to do another transfer and hit the cash register and just tell me everything's going to be okay and it'll work this time. And in their heart of hearts, they do believe that, especially if they have genetically tested embryos. But what if you're one of the women that's in that group that is just destined for failure because you have silent endometriosis? And even though you don't feel anything, there's just havoc wreaking on your uterine lining that's preventing you from getting pregnant or staying pregnant. And that's where the ReceptivaDX test comes in. So I'm going to try and not put my commercial hat on and try and promote this test, but I want to make sure you understand exactly what the test does. So you do an endometrial biopsy, which is done either in a natural cycle, which is you do your ovulation detection and you do the test 7 to 10 days after the ovulation, or in a mock cycle. And that's for women that are going through IVF. Instead of going through an IVF cycle where they do the transfer, they instead do the biopsy at the time they would have done the transfer. So the cool thing is you can do the biopsy during a routine office visit. You don't have to be scheduled in a surgery center. You're not put out under or anything like that. I'm a guy, so I'm not going to tell you it's not a painful experience. I know it's a painful experience for women, but the discomfort doesn't last that long. You might have some light cramping for about 15 minutes or so after the procedure, but most women go about their day and don't have any issues or complications as a result of the biopsy. We provide these kits that are free of charge that have our collection materials in there. The sample, it's put in formalin, which is a very stable sample. It preserves it, so it allows for shipping over to our US lab locations. And what we're real excited about now is in the past 6 months is that we've worked out a deal with DHL Express. So before, folks that had wanted to use our test had to cover the shipping costs. And I felt horrible about that. I would try and work with them on pricing, but they just couldn't get great pricing. So now I'm pleased to say it's all part of our charge for the testing. You don't have to pay a thing. You don't have to go and figure out how to take a sample to a FedEx thing and try and figure out how to send it. So we're very excited about our relationship with DHL. We have samples coming from all over the country right now, or all over the globe, I should say. And it's worked out very well. Results get back in about 7 to 10 days to the doctor. So that's great. It allows that information to happen so they can make decisions before proceeding with another cycle if treatment needs to be done. And we're just excited that we can reach out more globally now with the test. Uh, First of all, it's very sensitive and very specific for endometriosis. Again, we use endometriosis detection because we're not diagnostic. Again, diagnosis can only be achieved by scoping. But here we are with something that can be done years ahead of time before you might even qualify for laparoscopy or be able to afford it. This can help kind of create that pathway. So when we say 93% sensitivity, that means this test has been demonstrated that 93 out of 100 times, 100 cases of endometriosis, we're going to find it 93 out of 100. So not perfect, but 93%, that's pretty good. The specificity that you see of 96%, that means that 4% of the time, it's not endometriosis. It could have been something else, like a blocked tube or something like that. So it's not perfect, but 96% is pretty good when you're trying to find answers to a very challenging situation. So with those kind of sensitivity and specificity, the doctors can feel confident about assuming most likely it's endometriosis, and let's go do something about it. Just the one quick thing, if you did test positive, your chances in IVF, for example, without any intervention, and this pretty much applies to natural sex and conception as well, you're 5 times less likely than somebody who tested negative for BCL6. So, if you're a consumer and you're looking at the investment of another round of IVF, it's almost rolling the dice. Why would you do that without considering an intervention, especially if you've gone through 1 or 2 failures already and have invested that money? It's time to do some type of intervention on that. So our test is well studied. There's lots of outcome data. I'll share just a little bit with you in the next couple slides. But more importantly, to help you, is that 65% of the patients on their first transfer attempt after treatment, after testing positive for Receptiva, were successful. And that's better than our original data. Our original data had like 50% success rates, which is still good because we're talking about a group of women that are at wit's end. They have spent tens of thousands of dollars, and they were getting nowhere. And we're able to help a good percentage of them. So we're very excited with the success rates and the success stories that we're getting back. I mean, you are an N of 1. And I think it's just you owe it to yourself to get as much information before you make decisions or talked into doing another round and you're not comfortable with going forward. Maybe your marriage is at its wit's end because this is putting a tax on that. There's physical qualities to this whole thing, emotional things and everything. So it's just good information that is helping a lot of women make decisions and treatment interventions before just going ahead and doing another transfer, keep trying and experiencing loss or implantation failure. So this is just some interesting data just to let you know, for those of you that have gone through IVF, this was a group of 33, 37, 30, around 4,000 women. And this is grouped by failures. So these are women that have gone through IVF, had 5 or more failures, is that green box there. 71% of them tested positive for BCL6. So the more experience you have with IVF failure, the greater chance you're probably positive for BCL6, and silent endometriosis was the culprit. So just to give you an idea, what I really appreciate about this chart is under the heading of 1 to 2 failures, there's almost 3,000 tests there that were after 1 to 2 failures. When we first started this company 7 years ago, the majority of the test requests we got, women were coming in 4, 5, or 6 failures before they got tested. The average now is about 2 failures when testing happens. And we really feel good about that, because you think about the money that's being saved, the interventions that are happening earlier. It warms me to know that the doctors have embraced the test and are willing to have that discussion with the patient. let's try something different here before we just assume we can do another transfer and just hope for a better result. Now they can do something. So real briefly, this is our shared experience program where we have our big clients around the world. A lot of them are here in the US, named facilities, and we ask them to, reproduce our data. Is the data that we generated, that our experts, is it online? Is it accurate? And it's very exciting because these are 10 independent fertility centers, 890 women that we tracked here. And 62% of these women with failure history, the average failure history was 2 failures. 62% tested positive for BCL6, 38% tested negative. So all of a sudden, there's 2/3 of these women going, I may have an issue that I didn't know about. I may have a pathway now that I didn't know about to treatment and success. And that's what's exciting for us. So when we present data, we have to talk about pregnancy rate and live birth rate. Honestly, I know you're most interested and should be most interested in live birth rate. 58% is the live birth rate after the first IVF treatment, transfer after treatment for a positive Receptiva test. 58%. Our original data was 50%, and our clients are getting better than us. Some are even reporting higher. That's an average out there. The pregnancy rate, yeah, that's impressive, but obviously you want a full-term pregnancy. So I focus on the live birth rate for you as a data point. The good news is for the women that tested negative for BCL6, it also gives you assurance that inflammation is not the issue and that your chances for success going forward are really good. In this case, 2 out of 3 women were successful on their very next transfer that tested negative. So there's all kinds of reasons why someone can't get pregnant. We're not the end all, but we are definitely helping a group of women that are beyond frustration and giving them a path and a treatment towards and a pathway towards pregnancy. And very excited about that. And this is a treatment graph that I just wanted to show you. The green that you see is the women that were on Depo-Lupron. The coral color that you see are the women that had laparoscopy. And as you can see, they're pretty similar in success rates there. The gray that you see, the third column, are women that were in the control group that decided to have no treatment at all. And you can see their success rates going forward were very poor. And in the final columns over there, the miscarriage rate, the women that got treatment, whether it was laparoscopy or hormone suppression therapy, their chances for miscarriage dramatically reduced compared to women that were in the control group that didn't receive any treatment. So again, this goes back to how long do we keep doing the same thing without some type of intervention, expecting a different result, expecting to be able to get pregnant, expecting to be able to get through the first trimester if you do get pregnant. That's where we're really helping a lot of people with the BCL6 Receptiva test and giving them that information. All right, so if I did my job, I got you all excited about this and you're interested in finding out more about testing, what do you do? Well, a couple of things. I know all of you are dying to have another app on your phone. I know you are, but you can go to the Apple or Google Play Store and you can download the ReceptivaDX app. Anything that we talked about here today is probably going to be on there. It'll tell you about the test, when it should be biopsied, what the results mean, what the treatment options are that we talked about here. More importantly, it's great talking points, and you can share the app with your physician office. And it's one of those great moments you get to educate your doctor on something they didn't know about. How about that, huh? I make fun, but the reality is they have so many different things they're trying to learn. It's very hard for them to keep up with everything. But I will tell you this, you have to be your best advocate. If you're waiting for other people to solve these problems for you, and not think out of the box, I think you're at a disadvantage. Use this information to your advantage to become a stronger advocate. When you do talk to your provider, the 2 things I always urge women, and I talk to hundreds of women every year that call for consults, is that you need to make sure your doctor's on board with the test. Don't let them just humor you that they're gonna let you do the test. You need to know if they're really ready to treat based on that result, because that's a conversation you need to have up front, because now you're in an awkward position. You have a test result that should be acted upon, but you have a provider that doesn't want to do anything. So you owe yourself a favor to have that conversation up front with your doctor, not just being on board with testing, but on board and understanding the treatment options that you may want to pursue. I did a terrible job on this graphic here about what our email address is. That got reversed out, but info@receptivadx.com. You can email us. You can have a kit sent out to you. We send out kits, no charge, everywhere in the world now. You just pay when you get the test done at that point. But having a test in your hand does a couple things. Number one, it makes sure that the collection kit is there when you have your biopsy done, because sometimes doctors' offices, if they don't have our test stocked routinely, they don't know where the kit is. And here you are ready for a biopsy, and they're running around trying to find a DHL package or a FedEx package to get the kit out. So we always give you that option of having a kit there. The good news is we have over 450 centers around the globe that stock our kits. So a lot of them are very familiar with our tests, but no issues. More than happy to send you a test kit so you have that on hand and ready to go with your doctor. I think that's it, other than the questions and answers that we have there. Very good.
Brilliant. Thank you so much, Chris. That was very thorough as always. And I hope it's answered a lot of people's questions, but we do have some great questions that have come in. Can endometriosis develop over time?
And so as you see there, it's important to understand we don't know how endometriosis starts and when it starts. It can happen in early adolescence. It can happen later on in life. There's no rhyme or reason to this. We do know the longer it's there, the stronger chance it has of causing some of that damage that we talked about, not only to the ovaries, but just the scarring that can take place. One of the interesting things is that a lot of women will get this after having children, and they'll say, I can't have that. I've already had 2 kids. This can't be me. Well, every pregnancy is different. And the fact down below kind of attests to that in a single pregnancy, a woman produces more estrogen than they will the rest of their lives, just in one pregnancy. So every pregnancy is a whole new situation. And the amount of estrogen that's going through your body at that time, and remember, estrogen is the trigger for all that inflammation. It's what's inflaming those lesions and everything. So it can, endometriosis can develop over time. And that's why we have this test out there, because I'm really concerned about a 24-year-old who's not worried about their fertility yet, but really needs to get a diagnosis of endometriosis much sooner, because they will be a fertility patient 10 years later and be going through this. And they will have some just scarring or other damage that could have been caught earlier. So we really just don't know.
Does the inflammation caused by endometriosis make your body think it's being attacked and possibly trigger increased white blood cell count?
Well, and that's what inflammation is. Inflammation is white blood cells. It's rushing to the site where it thinks there's an issue, whether it's you've fallen and your knee swells up because you've banged your knee up or what have you. It's the body's repair mechanism. In the case of the uterine lining, just imagine in a healthy uterine lining, this lining is developing, it's enriching, it's ready to accept an embryo. And I always compare the analogy to a garden. You've got this beautiful garden and you're ready to plant these beautiful roses. And you've got to have great roses, you've got to have great conditions, you got to have great timing. Well, what if you come out and in the days that you're planning to go, there's this white film all over it? The roses aren't going to grow. It's disrupting the soil. And so that's what inflammation is. It's this unwanted house guest showing up at the worst possible time when you're trying to conceive. And that's why we do the test 7 to 10 days after you ovulate, because that's how long it takes the estrogen and the progesterone to manifest this inflammation that you see. So yeah, it's telling the body something's going on, and it's basically attacking. And it's also the reason why some pregnancies are lost. Some women can get pregnant, but they can't stay pregnant. And that's because that inflammation is undermining the role of progesterone as well as the environment. You got to remember, progesterone, it's an interesting thing. Progesterone is the main ingredient in birth control pills, right? It's tricking our body to thinking we're already pregnant. Well, that's what estrogen does. It signals out to the body, hey, we're pregnant, do not ovulate, do not have any more periods, anything else. Let's protect this embryo. Well, endometriosis disrupts progesterone, and there's a phenomenon called progesterone resistance that occurs in this whole cycle when this inflammation is there. And if progesterone is blocked from doing its job, guess what? The pregnancy can terminate. And that's why you hear about a lot of first trimester pregnancies, especially the ones that aren't attributed to a genetic abnormality. It's a good chance it was this inflammation that disrupted everything because progesterone was blocked from doing its job.
Can pregnancy heal endometriosis?
Interestingly enough, the answer is yes. I just spoke with a doctor, and then I called our expert, Dr. Lessie, because they wanted to know. They had a patient that had a successful pregnancy, had an IVF transfer after going through treatment after a positive Receptiva test, and they wanted to know, hey, do we need to test again? And the answer is, well, you don't need to test again. Some people might want to go through the Depo-Lupron again just as a safeguard. But Dr. Leslie, when I talked with him this morning, he mentioned 4 different cases where the pregnancy helped get rid of the endometriosis and also allowed them to conceive naturally without having to go to him for help. And he was pleased. He's university based, so he's happy about success stories without worrying about the financial consequences of not getting another IVF transfer. So it is possible, and they do believe pregnancy does help because it's doing the same thing. It's shutting everything down. You're not ovulating. You're not having that estrogen feed that inflammation.
Another question. What are the signs of silent endometriosis? Are there any?
Well, as by the name signs, a silent endo, you're not feeling any of the physical symptoms. The infertility is generally the only one, and that's why it comes up. But having said that, it's kind of a reminder to think about things, because as women, we all do this with pain, and we just chalk it up to that. And our body is this miraculous ability to just say, well, that's me. I have to deal with this. But then all of a sudden women are going, gosh, I never thought about it. I do have painful intercourse. I do have painful bowel movements as my period's approaching. So it wasn't really silent. They just didn't associate it with endometriosis. They just thought it was part of their cycle. But by and large, there are no signs, physical symptoms when you have silent endometriosis other than your fertility. And that's why healthcare providers obviously aren't looking for it. If you're not bringing it up and complaining about it, no one's going on a hunt to go look for things.
Absolutely. What are you actually testing for with the ReceptivaDX test?
So kind of already covered that, but just as a review, we're looking for this protein called BCL6. So it's an inflammation marker. So when we did our original research, we went and looked at a bunch of healthy women and non-healthy women. And the one, when I say unhealthy women that were having issues, this protein was showing up and shouldn't be there. It's not supposed to be there. I mean, we all have inflammation going on because our body's always fighting things, but this was abnormal levels of BCL6. So we had this original proving study where we had those 93% sensitivity and 96% specificity. That is all attributed to a bunch of women that decided that they would be a part of a study where they agreed not only to be tested, but to be scoped, regardless of their result. So imagine going through that, willing to be scoped. It's great information. So regardless of being positive or negative, they agreed to be scoped. And so I think 62 out of the 65 women were found to have endometriosis that tested positive for BCL6. And so that's how that kind of came to be. So I think the other 3 women, one, we found absolutely nothing. One had a blocked tube, and the other either had an endometrioma or I'm not quite sure what it was, but it was another inflammatory condition. So again, that's why we don't call it a diagnostic. We call it a detection test.
Great, thank you. And what is the best protocol to get pregnant after the removal of silent endo?
Sure.
So a chance
to review those 2 options that we already talked about. Surgery obviously being the most common and the most effective, and then the hormone suppression therapy. So again, the only point I'll make here is that if you have lifestyle issues that we talked about that need to be treated, laparoscopy is your best option. If you don't have anything else other than your fertility issues, I think I told you 3 out of 4 women adopted the hormone suppression therapy instead. And that was 60 days of Depo-Lupron. They do 2 30-day injections, and they went right into a frozen embryo transfer cycle without having a period. They didn't want the estrogen to induce the inflammation again. And that's where we've had these great success rates.
It's actually a good question as well, because treatment after having this diagnosis, and you made a good point about checking whether your specialist, if you're with a clinic, is on board. What's the time frame for treatment before you would then have a cycle of IVF or try to conceive naturally?
So good question. With the Depo-Lupron, they go immediately into that frozen embryo transfer cycle. We had to educate a lot of doctors. They're like, well, they said, well, let's let them have a period so we can clear out all this medication and all that. Well, as soon as you have a period, we really don't know how long Depo-Lupron impact will last. So everything that we did in the studies went right into an FET. Now, for the women that had surgery, different story. And I defer back to the doctors that we've worked with for some time, and they leave it up to the patient. It really is a comfort level for the patient. Now, in that case, the endometriosis, for the most part, has been removed, so that the sense of urgency to do that isn't as great as the Depo-Lupron, which is just kind of a suppression. So it's really up to the patient how they're feeling. Most women jump into it the next month or what have you. They're ready to go. They want to do that, but it's really up to them. There's no timetable.
And you talked a bit about implantation failure and repetitive implantation failure, but just a bit more about the effect that this can have, the impact this can have, or silent endometriosis can have on implantation versus it being a genetic issue with an embryo.
The reality is we don't know. You go out and get 20 different opinions from 20 different doctors on this because they've had success with a patient with endometriosis. So a lot of it just depends upon where this patient's endometriosis is, and is it wreaking havoc on the ovaries? Is it causing a lot of inflammation on the uterine lining? How long have they had these issues going on? Is it impacting their ability to have an egg be released and transferred down to the tube to meet the sperm? I mean, we think about all these, everything that we learned in high school, how easy it is to get pregnant and everything you need to do to make sure you don't get pregnant. It's amazing when you see all the amazing things that happen with the body. Your brain tells the pituitary to release a hormone, which tells the ovary to release an egg. The egg has to be released and be able to go down a channel and somehow meet this perfect sperm to come together and create the situation. And then it's got to be able to travel down that tube and, as a fertilized egg, somehow embed in the perfect spot in the endometrium and survive all these inflammation and everything else. And so it's easier to get pregnant when you're earlier. Your eggs are stronger, they're younger, and everything like that. So I just think when you talk with your doctor, don't be surprised if they say endometriosis is not an issue, I get women pregnant. Well, I can tell you statistically, 40% of them won't. The reality is that we don't know who those 40% are going to be. So early detection, that's the key, is just early detection and getting answers as soon as possible so you guys can make informed decisions and not just, I just hate to see when families are victims to a doctor who just says, I can get everybody pregnant. You give me 6 times, I'm going to get you pregnant. Well, after 2 or 3 times, there's a whole different mindset in the patient and the partner compared to the doctor. You're questioning everything, not just finances, but emotions, the physical journey you've been on, whether or not there's some underlying cause that hasn't been detected yet. And you just have to be your own advocate in that situation, because we just don't know which women are going to be impacted by this.
Definitely. We've had some more live questions come in. Are you familiar with any saliva tests that are being used to identify endomarkers?
We are. We're actually looking at it ourselves. We've done some preliminary work. They're not ready for prime time as far as I'm concerned. I think there's a group out of France that has released something. I'm not qualified to talk about their test yet. The issue is, and we've been heavy into research on this, obviously an endometrial biopsy is telling us exactly what's going on in the uterine lining, which is where the action is, right? That's where you want to know what's going on. We would love to find a blood marker or saliva marker. We could open up this to so many people. The issue is that there are so many origins for endometriosis. You can't be sure that a saliva test is going to pick up all cases. You can't be sure a blood sample is going to pick up all cases, especially if it's a marker of inflammation like ours. You have inflammation throughout your body. How do you know it's specific to endometriosis? So as encouraged as I am and as excited as I am, I just don't think there's enough data out there yet. So we're part of that race to find something. But if you're trying to get pregnant, I'd still pay attention to what's going on the uterine lining as opposed to just what's in your saliva. It would be great. It's non-invasive. Hey, we all love spitting in a tube rather than, getting up at the stirrups and dealing with the idea of an endometrial biopsies. But I'm not quite sure there's enough data out there on anything yet to just put your everything behind it and be able to treat based on that result or not treat. I think is the I'm on a wait and see attitude, I guess, as well.
Another question. This lady has been diagnosed with endometriosis and has had a laparoscopy to treat it. She's about to embark on a frozen embryo cycle and wonders if it makes sense for her to have the BCL6 test before the transfer.
A lot of it depends on how long ago the laparoscopy was, and maybe they can give us a little bit of information on their case. If it was recent in the past year, she probably doesn't need our test. I would love to have her do our test, but that's not necessary. If it's been 3 or 4 years, I can tell you the data out there in the published journals, endometriosis, for the most part, doesn't go away. It can be treated, it can be excised, but it's like a bad relative. It keeps showing up years later. And I think the statistic is about 40% of women that have undergone laparoscopy, depending on the type of surgery procedure, whether it was excised or burned off or the depth of it, a lot of it does come back. So it is an issue ongoing. And our test was really developed for women that did not have a previous diagnosis, but for someone that had testing or endometriosis confirmed 3 or 4 years ago and are not sure, this is a test that can be offered. A lot of it comes down to really your embryo reserves. If you really have poor embryo reserves and are considering IVF, you may want to consider doing the test just to see if a little Depo-Lupron or something might help. But by and large, if you've had it in the past year or so, the laparoscopy, you don't need to have our test done.
What is the likelihood of getting pregnant after a stage 4 diagnosis of endometriosis?
This is a great question, and I checked in with some of our experts before I wanted to provide this answer. And as you can see, my very first comment, there is no absolute answer. And the reason for that is that staging with endometriosis has to do with where it is infiltrated and how deep it is and how difficult it is to remove. Some just can't be removed. Some are on the ovaries and they're afraid to touch it because they're worried about destroying the ovary and destroying the eggs. So a lot of it, stage 4, is the same as stage 1. It really is an individual situation on whether or not it may have an impact. Overall, though, when I did some research here, IVF is recommended in almost every case to help with women with stage 4 because it has to do with the complication of where it's at and most likely the need to avoid the tubes in the ovaries because of the condition. But it's an individual situation that isn't just something that the pathologist will get back a report and say, yeah, it's this, it comes out to stage 4 based on the laparoscopy findings. But it's really up to the patient, the provider to discuss, is this stage 4 going to make it difficult for me to get pregnant or be successful at IVF?
Yeah. Okay. Thank you for that. So we have more information, which you've already just mentioned, about how to download the app, talking with your provider, be ready to advocate for yourself. Any other sort of tips on getting tested and the next steps? I know you've covered this already.
Yeah, I just always tell women, be your own advocate. Do not let anybody put you in an age group or a statistic group to satisfy how they're going to proceed. Ask a lot of questions. As I said before, this is the Wild West of medicine, and you have every right to ask. And it may drive your doctors batty, but you are out there paying for a lion's share of this, or somebody your employer is, or what have you. You have every right to demand answers and ask what the basis of their decision is. Ultimately, I have women that will text me, and I call them frequent flyers, and they're researching and they're looking at every study out there, and they're really get to a point where it's analysis paralysis. And I just tell them, ultimately, you got to do what's in your gut. What your gut is telling you. A woman's intuition is much stronger than a doctor who's giving you 10 or 15 minutes of their time, and you're not going to see them for another 6 weeks. And I'm not trying to diminish the capabilities of doctors, but it's really about just empowering yourself to ask the right questions and not be a victim and just kind of go along with things if you don't agree with them.
Mm-hmm. Absolutely. I'm aware of time and your time. And we've got a great question that you've answered, which is, what is the role of diet, if anything? Please, can you tell us a bit more about inflammation and how you can help naturally with what you're eating and avoiding and taking?
Sure. I really appreciate this question. I am not a dietitian of any experience in nutrition and everything, so I want to be very careful about how I answered this, but it just makes sense. Inflammation overall is just not healthy. And we know there are certain foods, and I've got my whole list of foods that I love that I know are just not going to be fun later on. So, if you're it's just common sense, and we all know what those are. The other thing is that I want to make sure is the endometriosis is caused by inflammation, but that inflammation is influenced by estrogen. And it's fair to say that most things are not heavy in estrogen that we're eating that are going to affect this as this particular condition. But overall, every doctor will tell you that a healthy diet is important. And I always say consult the experts when considering diets. There's just so many different things out there. And I think your body's going through enough just to alter things at the last second, I think is just needs to have some expertise involved in it. And then obviously for those of us and I fit in this category, I could stand to lose 20 pounds myself, but for women going through fertility, and it's historically already documented, body mass, larger body mass has been linked to pregnancy loss. So it's just common sense to do the right things, but again, seek the right experts. Don't just go off everything you read on the internet and try something else. And that's about all I'll say, because I'm definitely not an expert in that subject.
How does endo get to the bowels?
It gets to the bowels because that's part of the pelvic cavity, and it makes it down there. This is an interesting thing where again, instead of your regular flow leaving the body as your period, it's going back out through the fallopian tubes and going out. And the first chance it has to hit something is the ovaries or the fallopian tubes. But the majority of women that are suffering extreme pain have it in their pelvic area, in their rectal area. And that's why the painful bowel movements come. That's why they have painful intercourse. And there's no rhyme or reason as to why or how it happens, other than just these implants are able to travel. And again, they just inflame every month. But unlike your uterine lining, it can't shed in the form of a period. So it bleeds, it swells up. And depending on what it's next to, your bladder, your rectum, that's where the pain comes from.
And Well, that makes sense. But another question that's coming, can an OBGYN do the biopsy, or is it just a fertility specialist, which is a great question?
It is a great question. Any healthcare provider that is skilled in doing endometrial biopsies can collect that. So any OBGYN can do this. The only time I ever get concerned, and it's just a conversation you need to have, ask the doctor, do you do a lot of these? Are you comfortable with doing them? And the reason I say that is not so much a health concern for you, it's getting an accurate sample. I've seen OBGYN, I haven't seen them, but I've experienced this with clients where we could not do the test because the OBGYN or a nurse practitioner was trying to manage the discomfort of the patient because they're going through this procedure and they're trying to manage their pain, but they don't go deep enough with the pipelle to get endometrial tissue. And so the endometrial lining, as it's developing, has this mucosa layer on top. Well, mucosa, great for helping a embryo, not helpful for us to get a proper sample. So an endometrial biopsy collected properly is the number one factor there. So that's a conversation you definitely want to have. And if they'll probably tell you they're not comfortable with it, but most of them are. That's not an issue. The next big thing is, can they assist you with the treatment? And can they recommend someone? If you're going to have laparoscopy, my gosh, do your research and get somebody who knows what they're doing. Everyone can do laparoscopy, but this is your body, your fertility, and go find the best out there. Someone who's experienced at this, knows what they're doing, knows what they're looking for. Very important.
Great advice. I feel like you've covered a lot. So thank you so much. And thank you for the great questions. I'm sure everyone will agree with me that it's been very insightful today. So thank you. If anyone wants to get in touch with the team, all the information is there on the screen. We also have a lovely unique discount code, which is TRB23, which anyone can use at checkout, or you can message the team to use it. So that's TRB23. So please do reach out to the team and have your questions answered. Find out if it's the right thing for you in your journey at the time you're looking at, and they'd be more than happy to help you and navigate you in the right direction. So thank you once again, Chris, and thank you everyone for joining.
Thank you very much.
Thanks, everyone. Bye-bye.
Bye.